Hello, and welcome to another live broadcast with MedStar Health. My name is Karen Zingle, and I'm so glad you're joining us today as we recognize Esophageal Cancer Awareness Month. We're here to talk about risk factors, treatment options, and most importantly, hope and survivorship. This disease often flies off the radar, but awareness and early detection can truly save lives. Whether you're a patient, caregiver, clinician, or passionate about maintaining good health, this conversation is for you. So if you'd like to learn more, stick around, share this broadcast with your friends, and ask your questions in the comments below. We'll answer as many as we can today. So first, I'm excited to introduce our panel today. We have Dr. Kevin Chen, a medical oncologist and hematologist who specializes in treating esophageal cancer. He's joining us from the MedStar Georgetown Cancer Institute at MedStar Franklin Square Medical Center. Thank you for joining us, Dr. Chen.
Thanks for having me.
And then we have Zeev Gamliel, a thoracic surgeon and chief of thoracic surgery at the Angelos Center for Lung Diseases at MedStar Franklin Square Medical Center. Thanks for joining us, Dr. Gamliel.
A pleasure. Hi, Karen. Hi, everybody.
Then we also have Dr. Stephen Ronson, a radiation oncologist, and serves as the medical director of radiation oncology at MedStar Georgetown Cancer Institute at MedStar Franklin Square Medical Center. Thanks for joining us, Dr. Ronson.
Thank you very much.
And we have Kimberly, who's joining us today, who is going through her cancer journey. She is a stage 4 cancer patient. And Kimberly, we're so grateful to have you today.
I'm honored to be here. Thank you very much.
Yeah. All right. Well, I'm going to get started with some questions. We're going to really start first with risk factors. And we'll start by understanding those factors, how they increase your chances of developing esophageal cancer, because that's really the first step toward prevention and early detection. Before we get into that, let's just start with the basics. Dr. Chen, can you tell us what is esophageal cancer?
Yeah, so esophageal cancer would be, I would say, abnormal, uncontrolled growth of a tumor in the esophagus. And the esophagus is part of our body that connects our throat down into our stomach. So where how food and drinks that we take by mouth travel to the stomach for digestion. So any cancer or any tumors that develop in that region we would call an esophageal cancer.
All right, thank you so much. Dr. Gamliel, what are the symptoms of esophageal cancer?
The symptoms of esophageal cancer are not always the same. Different patients can discover that something is amiss through different symptoms, but the common denominator is that they're at some point in their journey aware that something is seriously wrong. It might be very common to have patients with esophageal cancer present because food keeps getting stuck when they swallow. And when food gets stuck, it can be quite uncomfortable. Sometimes they can force it to go down by drinking some water. Sometimes even that doesn't help, and they actually have to regurgitate the food to relieve the obstruction. Typically, that difficulty swallowing will start with solid food, but as the cancer grows and the passageway in the esophagus gets narrower and narrower, food has more and more difficulty passing through, and eventually it can even be difficult to swallow liquids. And so what happens when all this is going on is that not only does food get stuck on the way down more and more often and more easily, but the patient has a lot of discomfort when the food gets stuck, very typically, and then starts having difficulty just finishing their meals. And as a result, their caloric intake decreases and they notice that they're losing weight because they're just not able to eat as much as usual. That would be, I think, the most common way for esophageal cancer to declare itself and to help the patient realize that, hey, they need to get this checked out. But sometimes it can be even more subtle than that. It can just be a cough or it can be hoarseness. And rarely the esophageal cancer can actually travel to faraway parts of the body and cause trouble there rather than causing it in the esophagus where it's originating. And so rarely it could even mean that the cancer has gone to the liver or the bones, and you might have symptoms in your lower abdomen, or you might have symptoms in a bone that's hurting, and that might be your first tip-off. But again, typically the usual way that patients with esophageal cancer come to medical attention is that they just have a tough time eating their food because it keeps getting stuck and they're losing weight.
Thank you very much for that. Dr. Chen, I'm going to go back to you. What causes esophageal cancer? Who's at risk?
Yeah, I would say it's complicated. Like most cancers, there's not always a magic bullet saying this is what caused your cancer to grow. It's a combination of things. I'd say some of it's genetics, some of the family history, family risk factors. Some of it is environmental exposures. And then some of it is just bad luck. As we get older, our body starts breaking down and more mutations develop that can turn into cancer. But I think some specific risk factors that we can control are things like smoking. That is a very high risk factor for almost every cancer. So every person we come across, we always tell them, please stop smoking. It's bad for you in so many ways and can definitely lead to this cancer as well. Alcohol use, and then also just obesity and an inactive lifestyle. So leading a healthy lifestyle can reduce your risk. And then something that we do know about is also just heartburn. So, obviously not every person who has heartburn develops esophageal cancer, but if you have long-standing heartburn for a long, long time, and it's untreated or not looked at, then that can lead to damage to the lining of your esophagus that we call Barrett's esophagus. And over time, that can then develop into a pre-cancerous situation that can then one day turn into cancer. So anybody with long-standing heartburn should see a GI gastroenterologist at some point and have some endoscopy to get screened. And that way you can catch it earlier and have much better outcomes.
Thank you very much. I did not know that. So that was something I just learned now. Who is at risk for esophageal cancer?
So, any of those patients, any of those people that smoke, have alcohol, obesity, and long-standing heartburn, I would say males have a slightly higher predisposition. Maybe that has something to do with the way our lifestyles, perhaps. And then there are certain people from certain parts of the world and certain family histories as well that can put you at risk.
Okay, thank you very much. So, Dr. Gamliel, I'm going to go back to you. So, you have these feelings that you might be at risk. You're having some symptoms. You want to get it looked at for potential diagnosis. How is esophageal cancer diagnosed?
So I think the most important part of the equation is the patient themselves, meaning the real challenge is to wake up and realize, hey, this is not normal. I have to get this checked out. And I can't emphasize that enough, because all too often people tend to tough it out and wait for things to get better as they are actually getting worse, and they wait too long to get checked out. So for those watching, I would just plead with you, if this is what you're experiencing, please don't wait and wait and wait to get it checked out. If something is really not right, get it checked out right away, because it's probably not going to get better on its own. The ways that we detect esophageal cancer primarily would be either through doing a barium swallow, where your primary care doctor might send you to a radiology facility that would have you drink some radio-opaque dye called barium as they're taking moving pictures or video pictures with x-rays to watch this dye go down. Those pictures can show us if there is a narrowing in the passageway as the liquid funnels down. If there's a narrowing or a place where it gets hung up on the way down, that is a tip-off. The main way that we diagnose esophageal cancer is by having an actual look inside the swallowing tube or esophagus. And this is an outpatient procedure that's usually done by a gastroenterologist or a GI doctor. Not a lot of prep involved. You do have to fast, but you'll come in for an outpatient procedure. They'll give you some sedation. And then when you're sort of in the twilight zone, they can go down your throat with a video camera and have a look inside to see what the lining of the esophagus looks like, to see if there's any irregularities or even lumps or bumps or masses in there or ulcers, and take some biopsies. And typically those biopsies might take several days to come back, but those biopsies are really what clinches the diagnosis and tells us this is or isn't cancer.
Okay, thank you. What happens after a diagnosis?
So when a patient is diagnosed with esophageal cancer, typically that's something that's going to require specialized treatment by a cancer specialist. And cancer specialists come in different flavors. Some cancer specialists use medications to treat cancer. Some use radiation to treat cancer. Others operate on cancer. Any one of those cancer specialists can evaluate a patient with a new diagnosis of esophageal cancer. As a chest surgeon, I very often evaluate patients with new diagnoses of esophageal cancer. And the catch in evaluating a patient is to determine how far along the cancer is and what sort of treatment options are going to fit that patient's general bill of health. So there are different ways of treating esophageal cancer, which I know we're going to get into in a little bit, but seeing a patient for the first time, we really aren't able to be certain what is going to be the best fit for the patient without doing a lot of tests. And so that's kind of the drudgery involved when you're showing up all scared that you have this esophageal cancer and wondering what's going to be. And the dissatisfier is we don't really have answers for you right away. It's kind of like a puzzle that needs to be figured out. So typically a patient will get sent for a variety of different scans to see if the cancer has traveled anywhere else in their body, and will get sent for tests of their heart and lungs just to make sure that they are a good candidate to tolerate aggressive treatment.
All right, thank you so much. Yes, we'll talk about treatment next, but before we do, just want to pause and welcome our viewers again. Thank you for joining us. We are here today talking about esophageal cancer in honor of Esophageal Cancer Awareness Month. So far, we've talked about risk factors, symptoms, and diagnosis, but we have more to share, including treatment options, and we're going to hear from Kimberly, who's going through this now. So stick around. If you haven't already, share this with your friends and family. And if you have any questions, send them to us in the comments and we'll respond to those. Okay, so let's talk about treatment. Like many cancers, treatment depends on the stage of cancer and your overall health. Dr. Chen, I'm going to start with you. As a medical oncologist who specializes in esophageal cancer, can you talk about the role that chemotherapy plays in treating esophageal cancer? Let's start with that.
Sure. So, chemotherapy, that is, what a lot of people out there associate with cancer. When they hear cancer and needing treatment drugs for it, they're going to immediately go to chemotherapy. Nowadays, there are more newer, different treatments from that, but chemotherapy still remains a backbone of our treatment. And, chemotherapy is typically drugs that go through your veins, but there are some pill formulations as well. These drugs, in different ways, kill things that grow fast. They usually block DNA. And so fast-growing things inside of our bodies are very much affected and killed off by these drugs. Unfortunately, of course, it kills other things in our bodies. And that's why it causes hair loss, it causes nausea, vomiting, it worsens your immune system, causes bleeding problems, nerve damage. So the laundry list of side effects from chemotherapy is quite high, but yet it is still highly effective in killing cancer. So as long as we, inform our patients, it is still a very, very important part of treatment. And we use them in esophageal cancer regularly. Sometimes it's in a situation given before surgery. Sometimes it's in a situation given with radiation. Whereas for our more advanced cancer patients, those where it has spread, it becomes really the most important treatment. As you're trying to kill cancer cells that are spreading throughout the body, a surgeon and a radiation doctor can't usually take care of all that. And so that's where our drugs come in, because it can attack the entire body. So chemotherapy has a lot of, a stigma attached to it, but, it is still a very, very, very important part of treatment in our esophageal cancer patients.
All right, thank you. What about immunotherapy? How does that work and who might be eligible for it?
So immunotherapy is something that, the cancer community has been very excited about for many, many years now, for, I think, very good reason. I mean, these drugs have been a major breakthrough for many patients across many different cancer types, including in esophageal cancer. They're advertised on TV all the time. I tell my patients, you've seen the commercials, I'm sure, for Keytruda, Opdivo. All these drugs are being advertised because of how important they really are now. These are drugs that are typically still given through the vein. There's not a pill or shot form yet, but what they do is they work very differently from chemotherapy. They stimulate your own immune system to attack the cancer. So it's a much more natural way, using our own body's defenses. Our immune system is supposed to kill cancer. That's what it's supposed to do, but cancer cells got smart and they found a way to avoid getting killed by our immune system. And so that's where these new drugs came in, and they're called checkpoint inhibitors. They take away this defense mechanism so that our own T cells, our own immune system can recognize cancer, kill it, and oftentimes keep it away. And specifically in the esophageal cancer case, in patients where we find a high marker on their tumor cells, something called PD-L1. If we find that high marker, we as cancer doctors get very excited because then we know that these immunotherapy drugs can be highly effective. So it's really been a big breakthrough.
All right. Yes. Thank you. That's very exciting. Are there targeted therapies available for esophageal cancer, and how are they different from chemotherapy?
So target therapy is another very exciting place in cancer treatments these days. For a long time now, we've figured out that every person's cancer is different. We can't treat every esophageal cancer patient the same way, can't treat a lung cancer patient the same way. Every single person's cancer is different. It's driven by different mutations. And for a long time, we've known that if we can just identify those mutations and find a way to block that mutation, that would be a much more specific, targeted way of killing that individual's cancer. So nowadays, we spend a lot of our time looking for these mutations. We have panels where we send off a patient's tumor sample, or we can even test people's blood now, looking for these mutations. And if we find a mutation that we know is a good target, we sometimes think we've won the lottery. That we found something that is so targetable, so effective that it can wipe away a person's cancer, sometimes fully. In the esophageal cancer world, I think there's two main targets right now, but that likely will change and increase as time goes on. HER2 has been probably the one that we've known about the longest. That's a target that we've known about for a long time in breast cancer, but then it was found in esophageal and stomach cancers. And there's been multiple drugs found that can target that HER2 mutation, for example, Herceptin, which is highly effective. And just about 6 months ago, a new drug's come out for a new target in esophageal cancers called Claudin 18.2. And there's a new drug called Vyloy that just got FDA approval 6 months ago. So there's a new target that's just now available for esophageal cancer patients that wasn't available just last year. So we can see that this is exciting times, that we are finding mutations, we're developing drugs to target them, and our patients will just benefit from it in such great ways.
Yeah, that is great to hear. So you mentioned various treatment options, and you even mentioned in some cases it's a combination of treatments that a patient receives. How do you decide which treatment or which combination of treatment to start with once you talk with the patient?
Yes, so I mean it's complicated, and that's why it's so important that we collaborate, with Dr. Gamliel, Dr. Ronson, as a multidisciplinary team. It's so important because it really does take a whole team to figure this out. And so for a new patient that comes in with esophageal cancer, we need to know what type of esophageal cancer that is. That's based on the biopsy. There's something called a squamous cell and adenocarcinoma, but we need to know what type it is specifically. We need to know the stage, of course, the early stage, late stage. That will determine, are we thinking more direct treatments, or are we thinking more global body type treatments? And then, as I mentioned, mutation testing, that's also now very, very important to personalize the cancer treatment. We want to know what's driving that person's cancer to grow. Is it more of a mutation-based? Is there is there an immunotherapy that's going to work the best because they have a certain marker on their tumor cells? So all of that is factored in. And then also the patient. Every individual person is different in terms of what they bring to the table. What is their age? What are their other medical problems? What kind of condition are they in? Are they very strong and robust? Are they coming in a wheelchair? We have to figure out what the patient can tolerate and what's best for them, because while we want to do our best and treat them, we need to make sure we're not harming them too much at the same time. So, we really have to take a lot of these factors in and work as a team to come up with a treatment plan.
All right, makes sense. Thank you. Speaking of the team, let's go now to Dr. Ronson to talk about radiation therapy. What role does radiation oncology have in treating esophageal cancer?
Thank you. Yeah, I'll echo what Dr. Chen said. It depends a lot on the stage of the patient, and the condition they're in, how healthy they are, how strong they are to receive treatment. So working closely with Dr. Chen and Dr. Gamliel, if a patient has a localized esophageal cancer that we feel they would tolerate kind of a full court press as far as treatment, we'll sometimes do what we call trimodality therapy, where Dr. Chen and I will do chemotherapy and radiation therapy together at the same time. And once we're finished, the patient goes on to surgery. So like Dr. Chen mentioned, the chemotherapy, immunotherapies, those are medicines that get into your bloodstream. They travel over your whole body, attacking cancer cells. The radiation is localized. It's focused at the site of the cancer. It's delivered in a way similar to where you would get a chest X-ray or a CT scan. You're lying on a table in a room and the machine kind of rotates around you. It targets the cancer in the area in question and delivers the treatment over the course of a minute or two. And the patient doesn't feel anything during that treatment. There are some side effects associated with the treatment, which we review with the patients prior to starting treatment. But the treatment itself is non-invasive. The other role that radiation can play in patients is more in the palliative setting. So if a patient has more advanced cancer, their primary treatment is going to be a systemic treatment, a chemotherapy, an immunotherapy, or a targeted agent. But if there's a specific area in their body that's causing problems, whether that is obstruction from the primary tumor or another area in the body, perhaps compressing an airway or causing pain, radiation can be utilized locally to that specific area to provide some additional treatment to alleviate whatever symptoms the patients are having. So the role for radiation in the more definitive setting for localized cancers, and then also in the more advanced setting.
All right, thank you very much. How long does a course of radiation therapy usually last?
It depends on the goals of treatment and the stage of the patient. Once again, for when we do the trimodality therapy and we're doing it with chemotherapy with the intention of sending the patient back to Dr. Gamliel for surgery, that's about 6 weeks of treatment, Monday through Friday. If we're alleviating some symptoms that a patient is having because of a specific area of disease, that could be as short as 1 to 2 weeks of treatment.
Okay, thank you very much. So what can someone expect if they're going through radiation therapy? You mentioned going through you're having a discussion beforehand, they're lying on a table, but can you talk through what that process is like?
Sure. So once they come in for their initial consultation, we set them up for what we call a planning scan. It's a CAT scan we do of them in our department in the position that we're going to treat them in each day. So we know where all of their anatomy is when they're in that position. On that scan, I draw all the areas that I want to treat and I draw all the areas that I want to protect. We can sometimes get a plan ready to go within a few days. In other cases, it might take us a week to 2 weeks. Once the plan is ready, then the patient starts coming in for daily treatments. It's usually Monday through Friday from anywhere from 2 to 6 weeks. They're in our department for maybe half an hour, 45 minutes, door to door. The treatment in the treatment room for maybe 10 minutes, and the treatment delivery only takes a few minutes. Patients don't feel anything during treatment, and they leave each day feeling the same way they felt as they came in. So I tell patients, if you're able to drive yourself in, you're also able to drive yourself home. The side effects are slow in onset. So a week or two into treatment, a patient might start to feel a little tired. And the other effects are localized to where we're treating. So radiation can cause inflammation and swelling locally where we're treating someone. So if I'm treating their esophagus, in order to get the radiation from the machine to their esophagus, it does have to pass through usually a little bit of lung tissue, which can cause some inflammation, might cause a dry cough. The primary tumor, if a patient's already having some obstructive symptoms, I always warn my patients, your symptoms might get a little bit worse before they get better. And that's from some temporary swelling at the primary site from the radiation. And soon thereafter, they usually see an improvement in their symptoms where the obstruction improves, but then they might end up with some inflammation in the esophagus. So the obstruction could be replaced with some pain with swallowing, but that inflammation goes away usually within a few weeks of completing treatment.
All right. Thank you so much for explaining that. We have one more treatment option to discuss, and that's surgery. We're going to do that next. I'm going to go to Dr. Gamliel. When is surgery an option for patients?
So the goals of surgery for esophageal cancer are really two. The first goal of surgery for esophageal cancer is to get rid of the cancer. And the idea is to get rid of all of the cancer in a manner that it won't come back. The second goal of surgery is to restore the patient's ability to eat. After you've removed the cancer, you need to connect things back up in such a way so that the patient can have a good quality of life and enjoy a nice meal. The esophagus is stuck pretty deep in the body, really at the core of the body, and is jammed in between a lot of very important structures. And so the operation is really a deep surgery, and it's a very elaborate operation because not only are you going in deep to remove this esophagus cancer that's stuck in the middle of a lot of important things, but then you also have to reconstruct the gastrointestinal tract so that the patient can eat. You want to do this surgery when you have an opportunity to cure the cancer. You don't want to do the surgery in patients who are not likely to be cured. And you also want to do this surgery in patients who are able to get through the operation safely without an excessive risk of complications. And so when we spoke at the beginning of the session, I was alluding to the fact that when I'm seeing a newly diagnosed esophageal cancer patient, I'm sizing them up to determine how far along their cancer is, and also how much of an operation are they able to withstand. The recuperation from esophageal cancer surgery is tedious, takes a while. I think that it is well worthwhile to go through it if you are somebody who is likely to benefit from the surgery. But if this surgery is not likely to get rid of your cancer, or you're not likely to get through without lots of major complications, probably better to skip the operation. So it's really not a one size fits all. The trick, in my view, is two things. The surgery is a long one, a difficult one. The trick is to time it right and to rely on help from your friends. And so, of course, the patient needs to rely on help from their friends to get them through, but I need to rely on help from my friends as well. And what I mean by that is I'm not likely to accomplish much if I operate on patients unless they have first gotten some treatment from Dr. Chen and Dr. Ronson to make their cancer more amenable to being completely removed. And this is really a very intricate dance that we do. We work together often and we work together well. And it is a tall order to get somebody through chemotherapy and radiation therapy and then have them get through an operation unless you really know what you're doing. And I am so delighted to be able to work with experts like Dr. Chen and Dr. Ronson who get their patients through their treatment and the patient is still in good shape to tolerate surgery. That is no small feat. Obviously, most of the hard work falls upon the patient, and I think the good news is that nowadays, Dr. Chen and Dr. Ronson have so many tricks up their sleeve for minimizing the side effects of their treatments that more and more I'm seeing patients get through this preoperative treatment without any major problems. And then the trick is to get them through hospitalization for surgery and get them recovering in a manner that they can really start to enjoy eating again. And thank God we have a pretty good track record in that regard.
Yes, thank you so much. That's a great explanation to get us started with this surgical section. What about different approaches to surgery? What are the different surgical approaches and how are they chosen?
So there's really, again, two components to the operation. The first component is removing the cancer. And we don't want to remove only the cancer. We want to go widely around the cancer so that we don't leave any cancer behind. And that means that thanks to Dr. Chen and Dr. Ronson, who really beat up this cancer before I get to it, that cancer is pretty much shriveled up by the time I get to operate on it. And then I want to go above the cancer and below the cancer to get widely around it. And so exactly how much cancer and where the cancer is lying is going to determine where the cancer removal is taking place. Typically, that'll either be the bottom 55 or 60% of the esophagus, or it might be 90% of the esophagus that needs to be removed. And that's really the first component of the surgery, is separating that tumor from the patient. And then depending on what needed to be done in order to get rid of the cancer, that determines what sort of reconstruction we do to put things back together again after we snip out the esophageal tumor. What we typically do is we bring the patient's stomach up from their abdomen to attach to what is remaining of their esophagus. And so if we've removed only the bottom 55, 60% of the esophagus, we'll pull the patient's stomach up into their chest and attach it to their esophagus here and wait for that to heal before we let the patient start to eat and drink again. Sometimes it's necessary to remove 90% or more of the esophagus, in which case I can make the stomach reach all the way up to the patient's neck and attach it to the esophagus in their neck so that they can eat. But that will mean that the patient has incisions in their chest and incisions in their belly and incisions in their neck in order to get all this done. The incisions are not a small thing to go through, but the good news is that they do heal very well in the great majority of patients, and ultimately they're not as sore anymore. Ultimately, patients can resume full unrestricted activity, and once their stomach has healed well to what's remaining of their esophagus, they can really enjoy eating again.
All right, thank you very much. How long does the surgery typically take?
I always feel a little bit older at the end of the surgery. It's pretty much an all-day affair. I like to take my time at this operation. I like to be meticulous and careful and thorough. And so the surgery can be done less tediously, but that's not what I favor. I really like to take my time and get it right the first time. I find that spending some extra time in the operating room not only improves the likelihood that I'll get rid of all the cancer, but it also reduces the risk of complications and increases the chances that the patient's new hookup is going to function well so that they can really eat in a satisfying manner.
Yeah, speaking of that, that's goes into my next question. What does recovery look like, and what are the lifestyle changes or diet changes, if any, that patients need to consider after surgery? Are there any support that we give for to be able to eat those type of things? Can you go through that?
Most often when I do the surgery, I will also place a feeding tube so that the patient can receive calories, nutrition directly into their intestine through a small feeding tube in their belly. That feeding tube gets hooked up to a pump that delivers feeding solution, and we typically recommend that that get done overnight so that the patient is not hooked up to a pump during the day. That way they're free to roam around, and then at the end of the day, they hook themselves up to get fed overnight. That I think, is a wonderful way to ensure that patients are being adequately nourished while things are healing inside. And then once the patient is really starting to do better with their eating, they can eat in the usual way more and more and rely on the feeding tube less and less until eventually we just remove the feeding tube and let the patient just eat.
All right, thank you very much. So that leads us to Kimberly, our patient who is joining us today. We really appreciate you being here. This is a really inspiring part of our discussion, survivorship. Living through esophageal cancer, I can imagine, is a journey, physically, emotionally, mentally. So want to hear from you, Kimberly, and honor you today, and all of those cancer patients who are still in treatment. You're not alone. You might be newly diagnosed or years out of treatment, but the strength that we see from our patients is really what makes our jobs and things like Esophageal Cancer Awareness Month so powerful. So if you're a survivor or a caregiver, we welcome you to share your story in the comments. We'd love to recognize you. We're going to hear now from Kimberly, a patient who was diagnosed with stage 4 esophageal cancer. We have a beautiful video that we'll share in the comments with her journey. But Kimberly, let's turn to you now. You reference yourself as a thriver. What does that mean?
For me, a thriver means that I'm continuing to enjoy every day of life. Even though the treatment and the surgery and radiation were difficult, I still got up. I pushed through every single day. I kept as positive mindset as possible. When I was struggling myself, I reached out to others. I relied on my family, my friends, my doctors, to make sure that I could continue. And while one day might have been a difficult day, there was that next day. Even that hour that was difficult, but then the next hour was better. But as I've progressed through my 3-year journey so far since diagnosis, thriving is making sure that I'm living life and doing those things that I've always wanted to do. Many aspects of my life have changed, and there were things that I needed to reassess and of course put my health first. But I've been afforded opportunities and just have kind of let those opportunities take me where they are to be able to really enjoy my life and spend time with friends and family, my teenage children, my husband, and just live the best life that I can live.
It's wonderful. Yes. Um, Thank you for that. You mentioned you were first diagnosed 3 years ago. How did you find out?
I actually found out after needing to go in for an endoscopy. Food was getting stuck, like Dr. Gamliel explained. I was also experiencing a significant amount of hiccups. I went in, and Dr. Sankanidi at MedStar did an endoscopy, which he uncovered in a tumor, which he biopsied. That pathology actually came back very, very quickly through MedStar for me. But like Dr. Gamliel said, and Dr. Chen and Ronson, quick action, and many more tests. I think I endured anywhere from 1 to 4 tests a day the first month after my that diagnosis of, yes, it was esophageal cancer. But that allowed my team to set up the best treatment option and plan for me. And while it was, I reflect on it often, and I think about how those days were challenging, and sometimes I just felt like I was bouncing from doctor to doctor and office to office. It really is what got me to the point of being able to get through treatment, through surgery, and then to the point where I am today.
All right, thank you. And what does it mean to have stage 4 esophageal cancer?
Stage 4 means that it has spread beyond the original location. So in my case, I did get diagnosed with esophageal cancer at my GE junction, which is where my esophagus meets my stomach. Um, I did have a very early on a spread of lymph nodes outside my lung and to which Dr. Gamliel removed very, very quickly, so that we could then jump into my chemo and radiation. I have since had one reoccurrence. That spread to the lymph nodes in my neck and clavicle area. But with, again, the fast action of the MedStar team, I have now been free of radiological evidence of disease since spring of 2023.
Wow, that's great. Thank you so much. How has your life changed throughout this process? I'm sure very, very much so, but can you talk about that?
Absolutely. There were many, many tough days. I'm not going to lie. There were tough weeks. There were tough months. Um, but I really tried to remain positive. Some lifestyle changes that I'm still working on. I will forever need to sleep on an incline to limit the risk of aspiration, um, which can then lead to a host of other complications. Small meals. While many people might eat, a few snacks and then 3 meals a day or 2 meals a day, I kind of graze throughout the day, if you will. And sometimes that changes depending on the type of food. I've had to really experiment with what type of foods my body responds well to, and what foods it does not respond well to. And honestly, this far out from the surgery, I still am in trying to figure that out. It's really, but I have been able to go back to eating all the foods. I don't have any dietary restrictions with regard to foods that I was eating before that I can no longer eat now. I've been able, after weeks and months of healing, I was able to return to eating everything that I like. My energy level has been impacted. While my while I've been no evidence of disease and since spring of 2023, my treatment with immunotherapy and chemo just concluded in November of 2024. So I'm just a few months out, and that was 2.5 years of really intense treatment. So I'm still learning to give myself some grace, and I'm often reminded by my husband that I need to continue to give myself grace. This is not something that's going to change right away. So I fatigue hits very often, and so I have to be very careful. And then my immune system has been through a lot, so we take a lot of steps to make sure that I'm staying as healthy as possible when I'm out and about on a daily basis, the activities that I engage in, and then even travel as well.
Yeah, makes sense. How have you been feeling emotionally throughout this process? I'm sure it's been a roller coaster.
Absolutely. I mean, no one ever wants to get diagnosed with cancer. I always say that no cancer is a good cancer. Mentally, I have, and emotionally, I have remained hopeful. That's the thing. I remember my initial appointments with my doctors, and they instilled that hope in me that continues to drive me today. Honestly, it was, just many times cancer patients are encouraged, especially esophageal cancer patients, to get other opinions because it is a rare cancer and it is a significant impact on your life. But I came back to MedStar. Their care and the compassion that they have shown me through this process has really maintained my hope, including my nurses at chemo and radiation. And I acknowledge when I'm sad and I acknowledge when I'm having a tough day, but I really try very hard not to stay there and find the good and the positive. And it might take me, sometimes it's a couple minutes, sometimes it's a couple hours, and sometimes it's some heavy reflection, but I really try not to stay in any negative space that might pop into my head because, being diagnosed with cancer is hard. And then being diagnosed with stage 4 and what you often hear is associated as an outcome of stage 4, that can be a lot for anybody to process.
Yeah, absolutely. That's really inspiring. Thank you so much. What helps you stay positive or grounded during tough times? You mentioned positivity earlier. Can you talk about
I,
that?
I honestly, surrounding myself with positive people. Everybody has opinions of how somebody should go through a cancer journey. Everybody has opinions on what worked with their family member or their friend. But recognizing that, every cancer is different and every patient is different. So I really respect the choices that other cancer patients make, but then I want other people to respect the choices that I've made to treat my cancer and in my journey. So I love being surrounded by positive people. I try to find a great deal of peace in my life. The family and friends that, are included in activities and spend time, out getting outside, fresh air, and I've really been intentional in trying to engage in mindfulness activities and recently, with some help of modifications from yoga instructor, really started to do things to really help heal my body now that I finished the chemo and immunotherapy in November, but really to get my strength back and get myself to a place that I am comfortable with everything that I've endured.
That's great. We wish you all the best on that continued journey. What
Thank you.
are there any lessons or insights that you gained that you didn't expect?
Um, you know, I didn't expect that there would be so many opinions about uh, how people handle their cancer journey. And I really try to respect personally, like I had said, how everyone um, handles their diagnosis and progresses through that. I work a lot with other esophageal cancer patients. I was very lonely. There are times, even still, that I feel very alone. Um, some people will say esophageal cancer is a cancer where you're not going to find another person like you. I didn't necessarily meet the profile. I wasn't a man. I was, in my mid 40s. I was diagnosed by the gastroenterologist with having silent GERD. So I really was not experiencing really any symptoms that gave me any thought that I needed to be monitored regularly for endoscopies. So once I started choking on food and the increase in hiccups, that's when I knew I needed to make um, take that quick action to get in. Unfortunately, for me, it was stage 4 by the time that it was called. So really taking your health seriously. When you notice changes, making sure that you set up the appointments. I tell people often, our medical providers are wonderful, but there's few of them and so many of us. So if you suspect that something's wrong, you have to make sure you make that appointment right away because you might have to wait some time to get in. But then if things progress for you and get more serious, make sure you're taking quicker action, whether it's, through your primary doctor for referrals, whether it's, needing to go to an urgent care or an emergency room. Because like I think Dr. Gamliel spoke to, you want to, sometimes it's really far and very progressed by the time the symptoms hit. So just being as proactive as possible, but being as proactive as possible with anything related to your health.
Thank you so much for sharing your story, Kimberly. It's truly inspiring, and I hope that someone is out there listening who heard your story and especially your feelings of loneliness. And they're not the only one out there. And we just really appreciate you taking the time and again wish you all the best as you continue on your journey through survivorship.
Absolutely. Thank you very much for the opportunity.
Of course. So we did get some audience questions that I wanted to ask next before we wrap up. One of those I'm going to turn over to Dr. Gamliel. That question is from Allison, and she was asking about the reasons why there's an increase in esophageal cancer. We didn't talk much about that aspect, but she wanted to know what reasons do you feel contribute to those increases? What are your thoughts?
Thanks for your question, Allison. So the rate of esophageal cancer overall is not truly increasing. It's just that in recent decades, we've seen an increase in a particular type of esophageal cancer called adenocarcinoma. Adenocarcinoma is a little bit different from the other major type of esophageal cancer called squamous cell carcinoma. Squamous cell carcinoma tends to occur higher up in the esophagus and tends to be associated with lots of alcohol consumption or smoking. Other carcinoma is a little bit more mysterious, and the current theory is that it's probably more related to acid reflux than anything from the outside that we're subjecting ourselves to. So the explanation of why the incidence of adenocarcinoma has been increasing or increased recently is not entirely clear. The bottom line is it makes it a little bit difficult to target the people at risk because any of us could be at risk. And this is why it's so important for patients who are experiencing these really unusual symptoms that are persisting to not sweep them under the rug, but to get them checked out. I mean, Kimberly is about the last person that I would consider to be a poster child for esophageal cancer. And yet she was proactive. She took the bull by the horns, got herself looked at, and then proceeded to become the most important person on her healthcare team.
Mhm.
And that's what I would encourage everybody else to do, is to just advocate for yourself, get yourself checked out, and take the bull by the horns, because there is help for you and we can take care of you. And the idea is that we're not keeping you alive so you can continue getting treatment. We're treating you so that you can continue living your life. And that's the ultimate goal here. You want to continue living your life in a rewarding way, then don't wait, get it checked out.
Yep, absolutely. Great advice. Thank you so much. Another question came in from Carol. Dr. Ronson, I'm going to ask this question to you. She asked, is proton therapy an option for esophageal cancer?
Yes, proton therapy can be an option. Protons have the same effect on cancer cells as more traditional forms of radiation. We often use protons in patients who've already received a first round of radiation and their normal tissues have been exposed to the maximum safe amount of radiation. And the safest way to deliver an additional round of radiation is with protons. The key is if our target is next to tissue that is either exquisitely sensitive to radiation or has already been exposed to radiation, then protons provide a great benefit. In esophageal cancer specifically, the good news is that the dose we use in the neoadjuvant setting, which I would say is the definitive curative goal of treatment prior to the patient going off to surgery, the dose we use is pretty mild compared to some of the other types of cancer we treat. So, like I said, it's close to 6 weeks of treatment. Some of my patients coming in for other cancers are coming in for 9 weeks of treatment. So because we're using that moderate dose, the normal tissues around the esophagus, and we often include some of the regional lymph nodes, they're able to tolerate that quite well. So for esophageal cancer specifically, we don't see a great benefit in using protons because the dose being used is actually very well tolerated.
Okay, thank you very much. And thank you for your question. That is all the questions that I have for you all today. Before we close the discussion, anyone have any final remarks they want to share with our audience? Anything advice, anything we want to reiterate? Okay, I think we covered a lot today. So thank you, huge thanks to Doctors Chen, Gamliel, and Ronson, and to Kimberly. Thank you for spending time with us today, sharing this important information and inspiring messages of hope. Thanks to our viewers for tuning in, asking your questions. Let's continue to stand together for education, awareness, and every patient and survivor. So to learn more about esophageal cancer or to schedule an appointment, please visit our website. We'll put the link in the comment section. And with that, thank you so much for joining us. We'll see you next time.
Thanks, everybody.